Hi, everybody. I am Dr. Stacy Plichta, and today we are going to talk about continuous quality improvement in public health and healthcare. Continuous quality improvement has a really interesting history. The first wave was in the 1920s in the Western Electric Company. And this was the first time where statistical controls were used to try and improve quality, where measurements were taken, data was used, processes were changed, all in search of trying to make better quality. The second wave of CQI development was led by Japanese companies in the 1950s who had heard about the work of the folks at Western Electric Company, and Deming at W. Edwards Deming was one of the original folks who went over to Japan, and then Japan became a leader in continuous quality development in their factories. Then Deming came back to the United States and brought the principles of CQI to the US in the 1970s, and it was used largely in manufacturing. And somewhere in the 1980s, public health starts to use CQI, but more so after 1999, when the Institute of Medicine publishes the Quality Chasm about all of the terrible aspects of quality in US healthcare. There's a lot more interest in both public health and health delivery for using CQI. Public health departments faced increased expectations from the public to perform better. And really by now, healthcare delivery systems, thinking, hospitals, not necessarily individual doctors' offices, but systems, have adopted CQI principles and practices and have done so for a long time. So what is continuous quality improvement? Within public health, we define CQI as using deliberate improvement techniques. So it's intentional, focusing on activities that improve population health, making a continuous effort to improve and achieving measurable improvement. So the continuous effort to improve is the hallmark of CQI. CQI is not a one-time operation. It's intended to improve service delivery and process performance on an iterative basis. So CQI is data-driven. You can't improve anything unless you can measure it. That's one of the tenets of CQI. Processes, when we have a process, we have a goal for that process. We need to be able to make the goal measurable, and then we can measure our goal and see if we're meeting it. We can also measure our processes. The idea in CQI is that managerial decisions are based on the evidence from CQI data, and that data is shared with workers in a non-punitive manner. And this is really important because CQI is not about finding the individual to blame. That doesn't help anything. When we look for individuals to blame, people shut down. They do the minimum work possible. They won't talk about how things could be made better. They certainly will not disclose their own mistakes. But if the framework is that the mistakes are not the fault of the person, but the process, workers are much more comfortable talking about the processes. Most people in their job, if you ask them what works and what doesn't, they can tell you. They know because they're doing the work. So quality is really thought of as a system property, and to ensure that the process itself is sound. To achieve higher levels of quality in services and programs from a CQI viewpoint, we need to redesign public health processes, we need to develop new ones, we need to test them, and we need to improve them. One of the axioms of CQI is that only about 15% of the problems can be attributed to people, which means 85%, or the great majority of problems that we see in systems and processes, are really due to flawed processes. It's not about the individual person. It's about the system in which they work that leaves opportunities for mistakes. Now, CQI in public health was a tremendous movement, again, starting in the late 90s. Public health adopted CQI concepts through an iterative process and developed something known as the National Public Health Performance Management System. And this was developed in a partnership called the Turning Point Collaborative. The Public Health Foundation was part of it. These were initially developed in the early 2000s. The Public Health Foundation revised and revamped them in the spirit of CQI in 2012. And the idea is that they've been revised since. Their entire class is taught on nothing but this. I just want you to be familiar with it. If you want to know more, the website's here. I'm just going to briefly review it. So the idea is that surrounding this performance management system would be visible leadership, transparency, strategic alignment, which means the organization has to have a mission, a vision, values, goals, a culture of quality and a customer focus, thinking of the people that we serve as customers. So embedded within this performance management system are first having standards. We can't improve if we don't know what it is we want to improve. So what outcomes do we want to see? What processes do we want to see? What are the indicators? What are our goals? What are our targets? And the important thing is to communicate those to the people doing the work. And then we need to measure our performance. We may need to refine the indicators. We may have an indicator that we thought was good, but it wasn't. We need to develop data systems and collect data on a regular basis. And then as we're collecting this data, we need to analyze it, to interpret it, to report the results broadly, to invite feedback, to invite criticism, and to develop a regular reporting cycle so that we can see what in the system is working and what isn't. So the idea of quality improvement is when we have the standards, the measurement, and the cycle of reporting, we can use this data to make better decisions, to improve policies, to manage change, and ultimately to create a learning organization that continually improves. So part of what we do in quality improvement is to use deliberate improvement techniques. And I'd like to briefly go through several of these with you, keeping in mind each one of these could be an entire 15-week class on its own. The first one is to know about a logic model. So if we want to have a program, we want to know what impact do we want it to have. So let's start with, right? And in order to have an impact, we need to have outcomes. In order to have outcomes, our program needs to do something. So when we think about the end goal of our impact, we start by saying, okay, our planned work, we need resources and inputs in order to do this program. And when we have those resources and inputs, we're going to engage in a bunch of activities in order to, implement our program. Once we engage in these activities, we expect certain outputs. What are they? Once we've delivered the outputs, what are the outcomes? Did they benefit our participants? Did the service that we delivered and the outputs that we were able to do, did our participants benefit the way we thought they would? And finally, if the participants benefited, was there a larger impact in organizations or communities? And writing each of these out from what we have to work with, what we're going to do, what we want our initial output of our activities to be, what the outcomes we want to see happen with our participants, and the larger impact. Just writing that out and organizing our thoughts can go a long way towards implementing a program and understanding, how do we measure quality in that program? So, for example, inputs, what are they? They're staff, they're volunteers, time, money, research, materials. The initial inputs are all the stuff. And we make all kinds of assumptions as we go along, and it's good to write those down. The initial activities, we could think of them as outputs or part of the input, but it's what we do with all those inputs. We have workshops and meetings, we deliver services, we deliver products, we train people, we facilitate things. And then who do we reach, right? Who are our participants, our clients? Finally, what impact do we have? Short term. So short term, really, what are the output? What are our participants learning? What are they getting out of this? What longer term changes are we seeing in terms of their actions, their behavior, their decision making? And finally, what's the ultimate impact on society? And so when we have a program, thinking all of this through can really help us to organize how we want the program to be. So another thing in continuous quality improvement are process maps for quality. Process maps are a way that we can look at what it is that we're doing, identifying the major action steps and decisions in a process that we've developed to serve the public. It can orient the applicants to the application and assessment process. It can help, having a process map helps everybody. It helps the people working in the system understand the flow through the system. And we can show both core patient services and backroom processes as well. So here's a public health process map for pre-exposure prophylaxis. So pre-exposure prophylaxis is a medication taken by HIV negative people to help prevent the contraction of HIV/AIDS through either sex or IV drug use. So let's say we have a program in which we want to distribute PrEP to an at-risk population. Now, it begins, right? So when we look at a process map, the ovals indicate the beginning and end of a process. So a patient expresses interest. What's the next thing that happens? A process would be in that rectangle, in that rectangle. So the next thing that will happen is there'll be an assessment. There'll be a sexual history template. There'll be a PrEP navigator, and then there's a decision point. Does the patient have insurance? Because if the patient doesn't have insurance, they first need to talk to the benefits coordinator in order to find a way to pay for the PrEP. If they do have insurance, the PrEP order set can be placed in the electronic health record. But before somebody gets PrEP, there's a bunch of other activities. They need initial labs. They need to have an episode of care. They need to have a 1-month telehealth follow-up set in place. The labs need to go to the ordering provider. The lab results need to be documented in the electronic medical record, electronic health record. And then, does the patient have contraindications to PrEP? So all these things are set up. The labs are done. The appointments are scheduled. But the patient isn't going to start the PrEP, right? So if they don't have contraindications, yes, call the patient, review the lab results, remind about follow-up appointments, and then follow through the rest of this. If the patient does have contraindications, call the patient, schedule an in-person visit, address the contraindications. If they're HIV positive, that's one of the contraindications, deliver the results in person, link them to HIV care. There may be other steps in that process. And then the PrEP initiation process ends there. So this shows the flow through for folks, and the decision points are if they have insurance or not, or if they have contraindications or not, because different things happen for folks with or without insurance, and different things happen for folks with or without contraindications. And we look at a process map, we can see where some bottlenecks in service might be. So process maps can help managers to identify problem areas, to identify bottlenecks, like are there places in here where the volume of services, perhaps the volume of lab requests is going to overwhelm the lab capacity? Are there places where work must be done over because errors are being made? Is there a disconnect? Are client transfers, for example, for an HIV positive patient, is that transfer and connection to HIV care done well, or is that poorly managed? And are there redundancies? Are activities repeated in the process that don't need to be repeated? A great example of this is we've all gone to the healthcare provider, a doctor, a clinic, hospital, and we're asked to fill out forms. And on every single one of those forms, oftentimes we have to put our name, our contact information. We're writing things in several places that's redundant, that doesn't need to be done. A process map could help someone discover that. All right, now here is another continuous quality improvement technique that's one of my favorites. It's called cause and effect diagrams for root cause analysis. This is a technique for identifying all the possible causes, all the inputs associated with a particular problem, some output. It was developed by Kaoru Ishikawa, who's a Japanese control expert. And it helps us to narrow down the small number of main root causes of a problem that needs to be addressed. So the diagram looks like this. So if you see it, it kind of looks like a fish, like this fish skeleton. Problem is at the head, and then they're the main bones that come off that spine of the different categories of causes of the problem, things that might precipitate the problem. And within each of those categories, we have more details. And I'll talk about how we get those details in the next few slides. So here's an example. So one problem that a hospital noticed is that their patients get pressure ulcers. And when they examined all the reasons for this, they realized there were reasons related to the pressure ulcers resulting from staffing issues, from facility issues, from behavior issues, from process issues, and from education and training issues. And so I'm not going to take you through all of this, but I'll go ahead and take you through the staffing issues and then let you read the others on your own. So within staffing, we could say, well, why? And this is the 5 whys. One of the things that Mr. Ishigawa suggested was that to really get to the root of the problem, you have to ask why. Why is staffing the problem? Well, there's an inadequate skill mix and shift supervision. Not all the staff know to look for pressure ulcers. Not all the staff know what to do. Not all the staff know to turn the patient. Sometimes there's a staffing gap. Sometimes there's staff shortages. And sometimes there's a knowledge gap in pressure ulcer risk. And again, you can look at each of these main categories and say, well, why is the facility a problem? Why is education a problem? And when you're really doing this, you drill down even further. You would say, well, why is there inadequate skill mix and shift supervision? Why is there a staffing gap? And you keep asking whys until you run out of reasons. So why use these cause and effect diagrams, right? Aren't most problems obvious? Well, not really. We think problems are obvious. People working on a problem often jump right to the solution without studying the causes of the problem. And often one possible cause, the most obvious one, the most irritating one, is targeted and other causes are ignored. In most problems, there's several things underlying the problem, not just one, but without really looking at a cause and effect diagram or any way of examining what are the root causes, oftentimes actions are only taken to address the surface symptoms of the problem, but really don't get at the true causes. So cause and effect diagrams, they do a lot of things. We'll talk about exactly how to do this in a minute, but they stimulate thinking because you do a brainstorming activity. They provide a structure. When you look at that fishbone diagram, you can see the relationship between the causes of the problem and the problem. They give people a framework. Remember, continuous quality improvements about data collection. So once you have a sense of what some of the causes of the problem are, you can start planning what data to collect. They give a really good visual display of what the issue is, and they help team members communicate both within the team and with the rest of the organization. So here's what a generic cause and effect fishbone diagram looks like. Problem statement's always at the head. And then there's usually 5 or 6 cause categories. Some problems have fewer, some may have more. And for each of those cause categories, you should be saying, why is it a problem? Why is it a problem? Getting down to those smaller, they're called twigs on each bone, the smaller twigs or the smaller bones, if you will. And so here's how we could actually do this. First, we clearly define the problem. That's the head. Be as specific and detailed as possible. Use data, cite numbers, document your sources. For example, let's do one about the utilization of preventative dental care. So there was a county that was really concerned about the low utilization of preventative dental care. Think dental cleaning by adults in their county. Only 30% of their adult population had seen a dentist for any reason in the past year. So even not all of that was for cleaning. So they knew there was a problem. Then they were like, well, why? Why aren't people going to the dentist? So how do you do this brainstorm? Well, first you get a bunch of people, and not just people at the top. Get a patient, get a dentist, but get a dental hygienist. Get the people that clean up, get the janitorial staff involved. Get everybody you could think of involved. Use a facilitator if it's possible. Present details of the problem, but not the causes. And then brainstorm, go fast and furious. There are no bad ideas in a brainstorm, except there's one caveat. People love to jump to solutions. The point of brainstorming the causes of the problem is not to brainstorm solutions. So solutions cannot be part of the brainstorm. Those are the only ideas that you say no to. Focus only on the problem and its causes, and stop when the ideas are exhausted. So here are some examples of brainstormed ideas for why aren't adults in this county going to the dentist? Well, there are few providers have play spaces for the children. There's long wait times to be seen. Some of the clients don't speak English, and the providers have very limited proficiency in their languages. There's limited access to dental insurance. Dental care is expensive. People with disabilities, there's barriers for them. The government programs require applications and a waiting list, and there are a few specialists on premises. So if somebody needs advanced dental care, they may not be able to get it right away. They may need to wait. But, you know, so these are just some of the reasons that came out of the brainstorm. Some, are, as you can see, are more relevant to primary care than others, but there's no bad idea in a brainstorm. So after you have all the ideas, put each idea on a sticky note, and this way you can sort them into broad categories. Each of those major categories is a bone, and each sticky note is a smaller bone or twig attached to the larger category. And once you have those twigs, ask why. And keep asking why to get smaller twigs. Ideally, you get to 5 whys. This is also something Mr. Ishigawa developed. Then you draw the fishbone diagram. You place the problem at the head, you place the causes on the category bones and on the twigs, and then you look at it and you review the diagram with the group. You know, through the expert opinion of the group, you try to figure out which of these root causes seem to be the most relevant, which of these root causes can you do something about? You know, and that gives you a place to go to start to try to solve the problem and develop solutions. So here's what the fishbone diagram would look like for dental services. So the problems at the head, low utilization of preventative dental services in the county. And, you know, there was some date, the standard is 75% of adults should go, ideally 100%, but trying to be realistic about what can they reach. And then what were some of the causes of the low utilization of preventive care? Staff knowledge and skills limited, there's long wait times to be seen, the waiting room environment, the office hours are inconvenient, there's limited accessibility, and there's a time gap between the visit and the treatment. And again, I'll leave you on your own to explore off these main bones, to explore the twigs or the smaller bones, but you can see how the causes tended to cluster. Once the group has this diagram, they can start looking at the causes and then start thinking which causes make the most sense to address first, which causes can be addressed. And then they can, then there's a whole process by which you would start, set a solution, try out the solution, collect data, see if it made a difference, evaluate it, revise the solution. Again, continuous quality improvement is iterative. But this is just a great way to lay out a problem and its causes. Six Sigma, you'll hear about a lot. You can get certified in it. You can get certified in Six Sigma, and Green Six Sigma, and Lean Six Sigma. It's a process improvement technique, and it was developed for manufacturing environments, but it's used in other environments now. Again, people take entire courses in this. I just want you to know what it is. 3 key tenets. Continuous quality improvement is designed to monitor work output. It's intended to be applied throughout all departments in an organization, and the goal of Six Sigma is a maximum of 3.4 errors per 1 million operations. And again, considering this was originally manufacturing, that would be 3.4 defects per 1 million products, if you will. So Six Sigma model for CQI, it has a main goal of reducing or eliminating defects and deficiencies. And there's 3 categories of quality deficiencies in the Six Sigma view. There's underuse, and this outcome indicates that a service or program or process has not been utilized at an optimal level. There's overuse. This is a service or program in which the demand exceeds the ability of an agency to supply the services. And there's misuse, where services or programs are provided in a way that result in undesired outcomes or complications. So in the Six Sigma process, there's 5 steps. The first is to define and identify a problem in detail. The second is to measure the problem and its components. The third is to analyze, study the steps in the process, study the data. The fourth is to improve, implement a solution. And control means to apply data collection and monitoring. Control means knowing what is going on through the collection of data and then being able to go back and say, okay, did this solution based on our data make the improvement? And if not, we define the problem again, then we measure it, then we analyze it, and it's an iterative process. And this is the end of this lecture. There's another quality improvement technique called Plan, Study, Do, Act, PDSA, that we will be covering on its own in a different lecture.